Good morning. Here we have this treatment of iron deficiency anemia. The curriculum of both BDS and MBBS has this question: describe the hematinics and state their use in different types of anemia. So we have uh, different types of anemia related to hematinics are iron deficiency anemia and megaloblastic anemia due to vitamin B12 and folic acid deficiency. So first we will be dealing with this iron deficiency anemia. First of all, according to the curricula, what is hematinic? Hematinic is any nutrient required for the formation of blood cells. With that, we have two main kinds of nutrients, two main categories of nutrients required for the formation of RBCs. They are iron and another one is B12 and folate. These are categorized according to the anemia types they produce. So what is anemia then? Anemia is decrease in the amount of red blood cells or hemoglobin that results decrease oxygen carrying capacity, and hemoglobin binds to the oxygen reversibly and delivers it to the lungs and other tissues. So in absence of adequate RBC or hemoglobin, we cannot deliver desired amount of oxygen or the required amount of oxygen from lungs to the tissues. So this is what is anemia and what is the result of anemia basically. So what are the clinical features it produces? The features it produces is mainly due to the cell being hungry of oxygen, resulting in breathlessness, muscle fatigue, loss of stamina, and brain getting dizzy. And since hemoglobin is a pigment, in lack of the pigment we also have pallor. And to make up for the loss of hemoglobin, to make up for the inadequacy of oxygen, the heart tries to pump the blood very hard, so that what happens is there is increased cardiac output with resulting tachycardia or increased pulse rate and vasodilation. So these are the features due to cardiovascular adaptations. So these features are seen in every kind of anemia, whether it is iron deficiency anemia or megaloblastic anemia, because the cell is demanding for more oxygen and it is a pigment, and heart try to compensate. So with that, so what is iron deficiency anemia then? We have known anemia. Then what is iron deficiency anemia? Iron is an important raw material of hemoglobin. As we know that iron is important raw material of hemoglobin. More particularly, in one red blood cells there are hemoglobin, and in the hemoglobin, in the hem of the hemoglobin, there are iron molecules at the center of hem. So this iron is the raw material. So how much iron does the body contains? 100 ml of blood is equivalent to 15 gram of hemoglobin. So if you take 100 milliliter of blood, then it contains 15 gram hemoglobin, and this 15 gram hemoglobin contains 50 milligram of elemental iron. So in lack of the iron, the cells become small, and that is known as microcytic, and they become less pigmented or hypochromic, known as hypochromic or less pigmented due to less hemoglobin in it. So how will work for anemia in clinics, and particularly more towards the iron deficiency anemia? First we will see the features of anemia in a susceptible population. Susceptible population may be those who require more iron due to growth requirement, like growing children, lactating women, pregnant women, or those having increased loss of iron, like the one who is losing iron through menstruation or through stool, etc. So what we do is, in this susceptible population, we take a drop of blood and see it under the microscope, and used to or hematologist who has worked in this field will will instantly identify that it is microcytic or small erythrocytes and hypochromic, that is insufficient hemoglobin. The picture will look something like this. This is the normal one, and as compared to this normal one, this abnormal one is light, or this is hypochromic, and this and cell is also smaller, so it is microcytic hypochromic anemia. But the microcytic to one may look normal to another human being, so we have to find out some objective indices, and the one is mean corpuscle volume. This represents the whether the cell is microcytic or not, and mean corpuscle hemoglobin. This will there is another term also, mean corpuscle hemoglobin concentration. So these two indices will identify whether it is hypochromic or not, and therefore if these both criteria, microcytic and hypochromic, are fulfilled, then we are suffering from microcytic hypochromic anemia. But there are other causes of microcytic hypochromic anemia. One is lead poisoning, and another one is iron deficiency, and another is thalassemia, and another one is sideroblastic anemia. So if we could rule these three things out, these three things, then it is iron deficiency anemia, and it is confirmed basically by the total iron binding capacity and ferritin concentration. So this is the iron deficiency anemia workup. So once the person is diagnosed to have iron deficiency anemia, we like to start him with oral iron, and the indication of oral iron is therefore in the treatment as well as prevention of iron deficiency anemia, as we do it in the vulnerable population, especially the pregnant woman, lactating woman, and maybe in premature infants, children under during their growth periods, etc., and also those who have lost blood in a chronic chronic loss of blood, like the person who may be suffering from the colon cancer, may be losing lots of blood in a chronic period. So in these also we start this iron tablets as soon as possible. So and beside this, during the treatment of megaloblastic anemia, there is brisk hematopoiesis or hemopoiesis. The blood cell formation takes, or RBC formation takes place in the RBC secretion takes place in a very rapid way, and at that time the iron deficiency may also be unmasked. Therefore iron substitution has to be done along with the cause of megaloblastic anemia itself. So these are basically the two kinds of indications. So within this many diseases come, especially under this many conditions come. So these are the conditions in which we replace iron. These are the uses of oral iron. And preparations, we have this ferrous sulfate, two kinds of ferrous sulfate. Only ferrous sulfate, if we can remember ferrous sulfate, that's good enough, and ferrous gluconate and ferrous fumarate. And so what is we have to be concerned about is the how much elemental iron it gives, and per day we want 200 to 400 milligram of elemental iron per day. That is the desired amount of elemental iron. So we have to give this ferrous fumarate to 325 mg twice daily, and similarly we have to we may give this iron ferrous sulfate ferrous sulfate up to 4 times, so that it's above 200 mg, and even that 4 times is not enough for ferrous gluconate. So the basic idea is that the ferrous fumarate gives the maximum amount of elemental iron, and so we have these products like ferrous fumarate 300 mg. So ferrous fumarate, and it is often all the iron tablets are fortified with ascorbic acid and other acids, so as to make the absorption better, because in the ferrous form it is the iron is absorbed till if it is not heme iron, which is absorbed even in the ferric form. So these are also others in the market, ferrous ascorbate along with ascorbic acid and folic acid to make the absorption better. And so we have this iron 3 hydroxide polymaltose complex, iron polymaltose complex, and they say that it's better absorbed and it has less side effect, but it is not proven. And so how long will require the iron? The treatment with iron should be continued for 3 to 6 months, even after the correction. And this correction of the cause, for example, if a woman is suffering from dilutional anemia, or dilutional anemia that is seen in the later half of pregnancy, even after the delivery, when the cause is eliminated, cause for deficiency is eliminated, we continue to give iron for 3 to 6 months, because we want to correct the anemia and replenish the iron stores, because the iron store is replenished, so we want to restore that. So we use iron for not less than 3 months, even after the correction of the cause. And what are the interactions of iron tablets? There are certain factors which facilitate the iron absorption. These are acid will turn it into the ferrous form, so it makes it more absorbable. And similarly, meat produces hydrochloric acid, so it also is desired for iron absorption. And reducing substances like ascorbic acid, amino acid containing sulfhydryl radical, all this helps in iron absorption. On the other hand, factors disfavoring ones are the phosphates present in the egg yolk, or phytates in maize and wheat, and tetracyclines, which will chelate the iron. So altogether we have three factors that helps in iron absorption: acid, meat, and reducing substances. And disfavoring are phosphates, phytates, and tetracycline. So what are the adverse effects of oral iron? Iron is metallic, so it has metallic taste in mouth, which may cause nausea, vomiting, epigastric pain, and heartburn. Heartburn has nothing to do with heart. It is the term used for epigastric pain. It is also epigastric pain due to acid. We call it heartburn. Burn, when it is burn, it is not related to the heart, it is related to the GI system. And similarly, bloating and colic. So these are the side effects that we have on taking the oral iron. Similarly, iron can stain the teeth, especially the liquid formation. And besides, it can cause constipation as well as diarrhea. Constipation due to the astringent action, and diarrhea because it irritates the bowel, and it also causes alteration of the intestinal flora. That's why we have this diarrhea. And besides, there may be black stool, and black stool will confuse the patient if he is also having upper GI bleeding, because upper GI bleeding also produces the black stool. So patient gets confused whether it is due to bleeding or due to the iron itself. Thus we have five kind of adverse drug reaction with this oral iron. They are metallic taste, staining of teeth, constipation, diarrhea, and black stools. So acute iron toxicity is important in children, because sometimes they consume accidentally lot of amount of tablets, and the resulting condition is known as necrotizing gastroenteritis. And in this necrotizing gastroenteritis, as it is gastrointestinal, we have vomiting, abdominal pain, and it is necrotizing, so we have bloody diarrhea followed by shock, because it is bloody diarrhea followed by shock, lethargy, and severe metabolic acidosis. In shock, we always have metabolic acidosis. Almost always in the shock we have severe metabolic acidosis, and it might lead to coma and death of the patient. So how to treat the acute iron toxicity in children and infants? First, to prevent further absorption of iron from gut, we have to induce vomiting, and we have to do this gastric lavage. What is gastric lavage? Gastric lavage is something like inserting this pipe known as gastric lavage pipe through the nose, through the pharynx, into the esophagus, and into the stomach. And from this, and in this tube we inject the fluid like here we are treating with sodium bicarbonate with water, and we will inject this sodium bicarbonate with water into the tube, and it reaches the abdomen, and then we aspirate it, we take it out. That is basically, it is about cleaning the cleaning the stomach. It is cleaning the stomach, and to prevent the absorption of that poison iron from absorption, stopping the iron absorption by taking it back in the form of gastric lavage. This is gastric lavage. And beside gastric lavage, we can also give him egg yolk and milk, because it contains phosphates and it will help the absorption of iron. But activated charcoal, which is most often used in many poisoning, is not useful in iron poisoning because it is a heavy metal. And similarly, we can give whole bowel irrigation. Whole bowel irrigation is giving the liquid till the patient defecate and giving it all the time. This is all. So this is all about preventing the absorption of iron from gut, vomiting, gastric lavage, egg yolk and milk, and whole bowel irrigation. Besides, for those iron which have already been absorbed or already reached the blood, we give defuroxamine, which is a potent iron chelating compound. Defuroxamine, we give this drug, defuroxamine, intravenous defuroxamine. This is for already absorbed iron. This is an iron chelating agent. And for the supportive measures, we may have to treat this gastrointestinal bleeding with blood, metabolic acidosis with bicarbonate and other stuffs, and we also have to treat shock with the help of fluid and etc. These are supportive. These are important in almost every kind of poisoning if it becomes severe, but the most important are preventing the absorption and treating it with defuroxamine if it is already absorbed in the blood, and supportive measures are always there for any kind of poisoning. So contraindications and precautions of iron deficiency anemia. Absorption is if the patient is having too much symptoms, then we have to most of the time the iron absorption is taken in empty stomach. Why it is taken in empty stomach? Because absorption is better in empty stomach, but the patient may have side effect in the empty stomach. So what we have to do is we have to take it with meals or lower the dose or change the preparations. That I told you. It is claimed that the iron 3 polymaltose have less side effect. It is only claimed. And similarly, liquid formulations may stain the teeth, so you have to put it on the back of the tongue and swallow. And for the child safety, child-proof containers will be better. So these might be the contraindication and precaution of oral iron. So parenteral iron preparations. Indications is when there is non-compliance with oral iron, the patient is not taking the oral iron, or the patient is unable to tolerate oral iron. So there are unable to tolerate oral irons because of too much side effect. Even if you change the brand, decrease the dose, take it with meal, even if then the patient is having severe side effect, then we can go to this parenteral iron. And parenteral iron is the most in chronic kidney disease on hemodialysis and erythropoietin therapy, because when we give erythropoietin, the rate of synthesis of RBC is very fast, so as to cope up with this fast RBC formation. We have to give the intravenous iron, and oral iron is not enough. And for those people who are unable to absorb oral iron because of post-gastrectomy condition, because no SCL, less amount of iron absorbed, small bowel resection because because it is iron is absorbed through the small bowel. Similarly, inflammatory bowel disease involving the proximal small bowel, because iron is most probably, I think, absorbed in the duodenum. So, and similarly in the malabsorption syndromes, all these because where the site of iron absorption is disturbed by all these last things, except for this post-gastrectomy condition. So we have to use the intravenous iron or the parenteral iron in those conditions. So these are the parenteral preparations we have in the market. One is iron dextran injection and another is iron sucrose injection. These are the only two that we have in the market. And iron dextran is given either intramuscular or intravenous. We can give both intramuscular and intravenous this iron dextran, but iron sucrose is given only intravenous. Actually, the iron dextran is the only parenteral iron preparation, which can be given also IM, intramuscular. So we have iron dextran IV or IM and iron sucrose IV, and this sodium ferric gluconate complex, which I have not seen in our market. So adverse drug reactions. There are 3 adverse reactions with the intramuscular injection. These are the local pain at the site of intramuscular injection, local pain at the site of intramuscular injection, maybe pigmentation of the skin and sterile abscess. Once again, local pain at the site of IM injection of iron dextran, pigmentation at the IM injection of the iron dextran injection, and sterile abscess at the place where we give intramuscular iron dextran. Similarly, number 2 is hypersensitivity and anaphylaxis, and this hypersensitivity and anaphylaxis is very less with with ferrous sucrose. And last but not the least, if we give it in long term, then it may cause chronic iron toxicity. Long term, if we give the parenteral iron, it may cause chronic iron toxicity, which is also known as hemochromatosis. So these are the adverse drug reaction. One is with 3 with intramuscular, and then hypersensitivity and anaphylaxis, and then is ferrous sucrose causing low. Ferrous sucrose has low hypersensitivity, and we also have, if we give it long term, then we have chronic iron toxicity. What is chronic iron toxicity? Iron is tenaciously conserved by the body. Iron is conserved by the body. Daily excretion in adult male is 0.5 to 1 milligram, mainly as exfoliated GI mucosal cells, some RBCs, and in bile, and all lost in feces. And so we can, iron is very much conserved in the body. That means iron is very less amount of iron is excreted out of the body. So if we give the intravenous injection long term, then it might get deposited in the heart, liver, pancreas, and other organs, leading to their failure, leading to the heart failure, liver failure, pancreas failure. So these might lead to death. So treatment for this is phlebotomy. Phlebotomy is simply letting the blood go out of the body by cutting the vein or by opening the vein. It is just like letting the blood out of the body by opening the vein, so that the iron along with the blood goes out. So this is one treatment that has to be done intermittently. And another is the same iron chelator, deferoxamine, which is intravenous and more efficacious. We use parenteral deferoxamine, and as the oral iron chelator we can use deferriprone, which is less efficacious. So interactions, interaction I didn't find much. So we have contraindication and precautions. The required dose has to be, don't give all the required dose in the very first attempt. It has to be given in the multiple attempts. And owing to the risk of hypersensitivity reaction, a test dose of iron dextran should always be given before full intramuscular or intravenous doses are given. So you always have to give hypersensitivity test while giving iron dextran or iron sucrose. Though iron sucrose has less chance of getting hypersensitivity, we always practice hypersensitivity test or the test dose with the help with this parenteral iron preparations. And if the patient is hypersensitivity, this is contraindication. Avoid the drug for always. Thank you.